us earlier, 2 or 3 weeks ago, talking about. Did you share that with the team?
Yeah, I cleaned it up a little and took out his name.
Okay.
And the letters HPN, just so that you never know, So.
Yep. No. So our client base is as diverse as potentially the largest health system in a given state to the smallest independent producer or independent practice in the state. Our sweet spot still remains FQHCs because of the unique situation that they're faced with and how we work really well within them. In terms of just, it's pretty much the same everywhere. And I just got a notice here while I'm seeing it. We've had this already earlier today. My internet service provider is unstable today. We lost our complete service a little earlier. And it's running right now, but I just saw a flash and a warning come on saying that the system is getting unstable here. So just please recognize if that happens, you guys will have to ad-lib for a while.
Okay, I'm sure we can do that. Yep. We have a few very good ad-libbers in the wing.
I think the most important thing I can say to those who are members of your team that are on the call right now is that in time, we're going to say that our best targets may be a little different than what they are today, because as we start bringing in more and more prestigious clients that are highly recognizable because of who they are in the medical industry, our story will be a little bit different than it is currently. I still believe that the previous strategy that we've outlined is absolutely the best strategy possible with the 3 different types of customers that we're currently approaching. But as we start bringing on some of these additional health systems that, are operating 20, 30, 50 hospitals, and we're able to use them as very solid reference accounts, I think it will change the dynamics for going after some of the really, really large accounts in any given territory. The only trouble is that those typically take a long time to make happen, right? But the value proposition that we bring is identical. It doesn't matter what size practice it is, the value proposition remains pretty well unchanged. We enable the physicians to do what they still like doing, which is taking care of their patients, and we just provide them with the necessary infrastructure, the necessary tools, and if need be, the necessary employees to help them capture the revenue that is currently being incentivized on a payer agnostic basis. It doesn't matter. I just got off of a phone call just immediately preceding joining this call where we were talking with one of our partners where they are going to position us in with a managed Medicaid program for an entire state. And the managers of the managed Medicaid program are very intrigued with what we are doing. And so we're in the early stages of talking with the state Medicaid program director that might open up a 450,000 patient potential for us if we can all get on the same page for this managed Medicare program, Medicaid program, I'm sorry. That's a one-off. But what I hope the team hears me say is that the value proposition that we bring right now is the right proposition for the right time.
That's really fantastic, and waiting to be able to announce some news when it becomes official that you told me earlier.
Yep. That that'll be a really nice thing to talk about next week, is what I'm sure.
Yes, for sure. And let me just I don't know if you hear, Dave's not here, but Dave is a pharmacist. You've spoken with him. he met with the Northern Virginia Medical Association, which he joined as part of, compliance consultants back in January. So, we've been, dancing slowly with them quite a bit. And when he explained about the fact there was no upfront fees and no contracts, they got very excited. And I believe that we'll be scheduling a call where he'll be meeting with the board, and we'll be able to do a webinar to the board with you and Mr. Smith.
Oh, perfect. I would look forward to supporting that. And Richard, I don't mind talking about the client that I saw on Tuesday, the one I was telling you a little bit about. That's a independent primary care family medicine doctor with 2 nurse practitioners that work for him. He's been established there in that same clinic for 28 years. He has a very small Medicare population, 314 active patients, which, is nothing. I mean, that's a little bit lower than what you expect in a given primary care. Most of them have closer to 500 as an individual practitioner. But where we really saw an advantage for him, he had 2,400 active commercial patients. And he'd narrowed the field down between listening to our value proposition versus a value proposition put out by another company that specializes in doing annual wellness, chronic care management, transitional care management, et cetera. Very quickly, the differentiating factor was their entire patient population that the other company could work with was 314 patients. Our entire patient population that we could work with was the same 314 patients, but we also had all 2,400 commercial patients, commercially insured patients. And I was able to dive into his top commercial payer, and we asked the office manager to run a quick scenario based on a couple of codes that were being paid by that specific payer, and the rate that the commercial payer was authorizing for a complimentary preventive service, basically their version of an annual wellness visit for the non-Medicare patients, the ones who were not qualified for Medicare. The commercial reimbursement is actually higher in this particular clinic than what he would be getting for the annual wellness visit. So it was a very easy decision for this physician to make. He had 2 propositions in front of him, 2 proposals. One of them was 314 patients worth of potential revenue and improved clinical outcomes. The other was 2,714, where on the 314 patients, they get the same exact amount, but on the 2,400, they get a higher amount. It was a very simple decision for him to say, let me sign a contract. We are the only value proposition that I'm aware of. We're the only provider in the industry that can come in on a payer agnostic basis and make these things happen. There may be others out there. We just aren't aware of who they are. And we know that they certainly do not execute at the level that we execute at. So I'm soon to have another happy client.
Nice, sweet.
And again, I can't overemphasize how important that is, that we are payer agnostic and we are not simply working the Medicare roster.
Yeah, I mean, that's such a big difference between, everything we talked about for the last almost 2 years. Macro. How many Medicare patients do you have? How many are Medicare, how many are HMO, how many Medicare Advantage, and hoping that the numbers would, we'd have at least 2 or 3 a day that would fit. And now it's everybody every day. Big difference.
Yeah, and that is a big difference. He had a very small Medicaid population, and we looked up what we could do for his Medicaid people, and there's some opportunity even with his Medicaid population. So he was very happy that he took the time to actually sit down and compare, and he concluded that it was not an apples to apples comparison. You know, he did apples to apples comparison on all the other people that he talked to, all the other vendors, but along came a strategic partner, Practice Improvements Inc., with our high performance network and Geico process, and all of a sudden it was no longer an apple to apple comparison. It was apple to oranges or whatever else you want to say.
Yeah, we're very excited, and I just got a text that woman who should be here in about 2 minutes.
Yep, perfect.
I'm going to hit the.
And Richard, this presentation still has some of the ACO slides in them. I'll leave them in there, and we'll just work around those. That's not a big deal.
They are self-pay. They may be able to qualify for 4 different state programs that we offer. And within those 4 state programs, there's certain parameters that will cause them to be able to qualify for one of those services. So what we want to do is ensure that someone who is a self-pay that does not have any type of insurance has the ability to get medical services without the ability to pay for it. So along with those self-pay patients, we also see patients who have private insurance as well and have the ability to pay because they have private insurance. We see roughly, we now have 5 providers total, one being an OBGYN specialty and the other are family practitioners. So those practitioners see patients from a wide array of different services. They see someone for something as small as an infragment of, say they have a bite of some sort, to seeing someone for a surgical procedure or for anything to do with family practice. They basically see those patients, and I would say on an average, we see about I'd say each provider sees about 20 patients per day, and that's 20 patients per provider times 4, really, because the OBGYN just sees the type of patients that are OBGYN. So times 4, that's about 80 patients a day. 80 times we're open 6 days a week. So I would say on average, 80 times 6 is what? 480? 40, 6 times 8 is 48. So yes, 80 times 6 is what, 480?
Yeah, that'd be 480.
Yeah, 480. So we see about average about 480 patients a week.
Excellent. So, and my name is Ron Frost. Richard Harris Inc., a Fort Smith, Arkansas-based company, and our real forte, where we've got a really strong clientele base, is working with federally qualified health centers and rural health clinics. Optimizing their practices. It sounds like you're, like most FQHCs, really heavily grant-based in terms of how you're funded. Would that be correct?
Yes, that is.
Yep.
Yes.
So, do you have a lot of pediatric or adolescent patients where you're doing EPSDTs on a routine basis?
I would say we have average, yes.
Good. Well, you know, the value proposition that we bring to the table, understanding the methodology under which most FQHCs are reimbursed, we have found that we can actually, if you have excess physician time and you want to see additional patients, just the methodology by which we engage the patients and get them more active in their own healthcare and bringing them in to make sure that they are getting gaps in care closed. We've been able to successfully do that on a payer agnostic basis. And again, we work with several hundred clinics currently, with probably maybe well over 110 different FQHCs scattered throughout 7 states right now, that have found some value in the way we come in and work in optimizing the clinics through helping capture the various commercial monies that are available. If you do have Medicare, that's fine. We often have to get creative when we're working with patients that don't have insurance sources, looking at, what are the mechanisms for capturing or ensuring that their visits are paid for. But we truly do work in a payer agnostic environment. And what we typically try to do is just really analyze what gaps in care exist on a patient by patient basis, and help the clinic be able to close those gaps in care through evidence-based protocols that are, fairly well established. And what I'd really need to do is I'd really need to learn on this specific FQHC. I just need to look at them a little carefully and just see what their patients look like, as far as, understand the demographic that she was sharing a little deeper. But they fit the profile of so many of the clinics that we work with, particularly in Arkansas and some of the other rural areas. Now, are you based in the Houston metro area? Where's your clinic actually physically located?
No, we're actually not in the metro area. We're actually inner city. We are at Braeswood and Gessner.
Oh, Braeswood and Gessner. I used to live down off of Bissonnet Street.
Yeah, we're right. We actually we just opened a second location on Bissonnet.
I love visiting Houston. I currently live in Columbia, Missouri, but back in the first oil boom too many years ago, I won't even name when it was, I lived down there, and man, the traffic down in your part of the world was terrible back then.
It's worse.
I knew you were going to tell me that, because I still have friends there that have told me it's far worse than when you lived here, Ron.
It's worse, and there's many more freeways, and they're getting the freeways widened, and that doesn't help. Every freeway has at least 6 lanes, and a couple of them have those pay lanes and all that. It still doesn't work. Along with HOV, yeah, still doesn't work.
No, I know it. I would be lying if I say I miss the traffic, because I don't miss it a bit.
Yeah, I can only imagine. I'm blessed. I don't have to commute in, because I live out in Katy. But the way that they have opened everything up, West Belford goes all the way to 99 now, so I can come straight. Yeah. Good.
Well, let me ask a couple more questions here, and this is just your position in the FQHC. What do you see are areas, if any, in your own organization or in your ability to engage patients? What would you do different, or what things do you think could be improved if you had a magic wand?
If I had a magic wand, well, in all honesty, because we've undergone some changes in staff and we have increased our providers, it's kind of hard to tell exactly where we are now as opposed to where we could be in another 3 months with those providers, and then with the new location, as well as the other location that's getting ready to open up shortly after this one. So if I could wave a magic wand, it would definitely be to cut down on wait time, and the cycle time would be a lot faster, so that we could see more patients in the same length of time that we're seeing them now. And I think that will eventually change, because of the newness of the providers, and getting those cycle times reduced is going to be key. Yeah. So cycle time is where I could wave a magic wand.
Okay. And you're saying in the new clinic that will be opening or has just opened, do you feel the providers are working at capacity, or is it just they're working at capacity because they're only willing to see so many patients in the allotted time?
They're not working at capacity. I can tell you that. We definitely need to increase our cycles.
Okay.
And in order to increase those and in increasing those cycle times, we can see more patients.
And what kind of time do you guys currently allocate for seeing patients as a typical appointment?
Depending on the service, the minimum amount of time is 20 minutes for a routine lab or something to that effect. And then if it's a well woman's or an annual, that is typically cycle time is about 60 minutes now. And I would like to be able to decrease those well woman's or well child or well male exams down from a 60 cycle to a 45-minute or even lower cycle. If I could decrease that cycle down to 40 minutes, that would be perfect to me.
And do you have set infrastructure as far as IT that helps you in terms of a process or automation on doing some of these standard exams, or is it all just kind of being done on paper right now? Help me understand where you're at in that process.
We are in the middle of a conversion as we speak. We are changing our EHR system, and the new EHR system that we are converting to will be paperless. So everything will be paperless in this new EHR that we're going to. However, because we're in between the two right now, it's being done on paper.
I'm starting to get a clearer picture of the pain.
Yep. Yep. Pain is real, but it's getting better, because think about the pain that we endured before we got these other 4 providers. This one provider was seeing the number of patients that I just described to you that we were seeing. Wow. So she was here from the crack of dawn till the crack of dawn again, between trying to see patients and chart and do everything. She was doing it all by her little lonesome.
Yep. So one of the things I'm thinking about within some of the FQHCs with which we work, and I'm deliberately just not going through my slide deck right now. I didn't think to see if you're actually reviewing my slide or not, but just the nature of the conversation, I think it's more important for me to understand your practice before I would try to make any recommendations on what I think we could do to assist you. I'm just wondering, and I'm wondering out loud right now, David and Richard, that, we have the ability, and many of our FQHCs have allowed us to come in with our own personnel, embed some of the personnel to help speed up the process of patient flow through. There are certain things that make a FQHC, though, a little different in terms of the all-inclusive rate in which you're paid and your cost reporting, where a lot of times, ultimately, it's better for you to have your own employees doing it. But short-term, that might be somewhere where we'd be able to help speed up the process, is if we were to do some of the legwork that is not necessarily having to be done face-to-face at that moment, but then could just have your provider do the face-to-face at the last minute and round on something that we had already pretty well 90 or 95% completed. Do you think that would be something that might be worth exploring or looking at?
I'd be interested in knowing how.
Yeah, so David, what I would like to do, with you guys' permission, is to get a little bit more information, and then I would like to set up a time where we could actually answer that question on what a model like that would potentially look like. And what I would want to do is probably have our operations director, Sadie, field some of the comments and actually explain how that process works from an operational standpoint.
Okay.
But what we do have is we have we employ and we actually embed into practices what we call a CTC. It's a care team coordinator position, where we can actually help in fulfilling your well woman visits, your well child visits, your EPSDTs, etc. You're going to have probably some face time there with your own provider to compliantly be able to fulfill the service for billing. But a lot of what can be done expeditiously through our crew who does this routinely, we might be able to help you have the physicians actually see more patients on a daily basis because they're not spending as much time, and yet the full scope of service is still being performed.
Mm-hmm.
And that's something that we would just need to take a look at on an individual basis here, David.
Okay. Okay.
So, but basically, at the end of the day, we're still saying what we do, and what we do really, really well is we figured out how to optimize and improve the efficiency of the clinics within we work. And many of our FQHCs do start off allowing us to come in with embedded personnel. And while they're transitioning from, one EHR to another EHR, or it's a brand new location, there's a lot of different reasons why they may allow us in at the very beginning with our own person. But we believe, as do most of our clients, that ultimately, because of your unique way in which you're reimbursed on a cost basis, that ultimately you're better served if it's your own personnel who take over the responsibility once we've built a level of efficiency into the system for you. And I think it's certainly something we should look at doing.
Okay.
How many total locations does your FQHC operate?
We have 2 currently.
And did I hear you say you're going to be building another one?
Yeah, we're going to be opening another one here soon. We've already got it established. We actually have 2 that we've already got established. We've just got to get staff and get everything set up and ready to go. We're trying to see how this staff will fare out working in 2 clinics right now, so we can see how that works, how that's going to fare out first before we move forward with these other 2. And
Sure.
we've got a mobile unit, and we're about to add a second mobile unit as well for that.
Yeah, so I feel pretty optimistic that when we learn a little bit more about what your goals are, we'll be able to share some ideas with you on how we have worked with some other smaller FQHC operations such as you guys are describing, and how we've been a catalyst for one of our larger clients now. We've been able to optimize them so efficiently that they've been able to open up, I think it's 7 or 8 additional locations on a much shorter time frame than what they originally had anticipated, just because of the efficiencies of scale and the operations we were able to help them with. And the nice thing is, with our business model, if we don't create value that pays for itself, we don't get paid on anything. So this is not like something we'd come in and cost the clinic anything. The only time we would actually end up creating any revenue due to us is after we had already created the revenue on your side of the equation.
Okay.
So, Richard, if you don't mind, because I'm getting closer to a real hard stop that I've got at 2 o'clock, I think what we should do is get a little bit more homework, do a little bit more. I'll send you guys some information that we would request from you. And David, I'll send it to Richard and let Richard get it all out to you. And once we get some additional information, we might want to have another meeting at that point in time, just really to flesh out some details on what we think might be a process or a program that would really be custom to what their needs are.
Okay.
Okay. What I'm thinking about is if it's second half of next week.
Mm-hmm.
Probably Thursday next week at this time. That's enough time for you to collect your information.
Thursday I have an appointment.
Keep checking.
Friday might be better, David.
Yeah,
You-
Friday will work a lot better for me.
Friday, next Friday.
Yeah, so Richard, send me some times on Friday that would work. And what I've got to do, because I think I'll probably want Sadie, our operations director, to field some of this information. But I'll tentatively try to make arrangements for some time on Friday where we can get a little bit more detail, talking about how we might be able to do something.
Okay.
Sure, we'll do that. And I know you've got a 2 minutes to your next meeting. So thank you so much, Mr. Frost. And get me that info so David can get the answers so we can know better how we can help these folks.
Absolutely. So we'll have some conversation here within the next day or so, and we'll flesh it all out. Thank you so much for the time, everyone, today.
Thank
All right.
you.
Thank you, Ron.
Bye now.
Thank you, everyone. Bye.
Okay. Thank you, Richard.
Thank you.